Thank you, Dr. Abhishek. Thank you, Hindi team.
Okay.
Now we'll move to English session. Today is our 2088th day of continuous webinar. As always, we are starting with a silent prayer. Good evening and welcome once again. Today is our 2088th day of continuous webinar. We are conducting this webinar in 3 languages in every day without any break and without any leave for the last 2087 days. Thank you all the participants and faculties for your support and presence here. And today's our guest is Dr. RAXIT VISHPARA MD in Homeopathy. He is Assistant Professor in the Department of Practice of Medicine in Rajkot Homeopathic Medical College, Parole University, Gujarat. He is a consultant in Srinathji Clinic in Gujarat. And today's topic is about hyperthyroidism. And I am welcoming Dr. RAXIT for your speech. You are welcome. Please.
Thank you so much.
So happy to get you as a speaker today.
Thank you so much for providing me this kind of opportunity to share the homeopathy. Thank you so much. Can I share my screen?
Yeah, sure. Now you are the co-host. You can share the screen. You can start. It's visible. Please.
Yes. Is my voice is clearly audible?
Yes, you are. Your voice is clear. Your slide is clear, and you are visible also.
Thank you so much. So first of all, introduction. Myself, Dr. RAXIT VISHPARA. I'm an assistant professor, Department of Practice of Medicine at Rajkot Homeopathic Medical College, attached with Parole University, which is situated in Baroda. This my college situated in Rajkot city, as well as my clinic as a consultant homeopath. I running my own clinic, Srinathji Clinic, at Racecourse Park in Rajkot. Today's our topic is hyperthyroidism, or integrating clinical understanding with homeopathy. The aim, why should I select this kind of topic? You can search in Google. There are so many lots of cases of hypothyroidism, but etiologically we can see that there are so many less cases. There are prevalence rate is the lower side for this kind of disease. That is hyperthyroidism. So in homeopathic literature also, there is a less evidence, less research work available for hyperthyroidism like cases. So in clinic also, I have a running special clinic for this kind of diseases, hyperthyroidism like cases. Let us start. What is the clinical challenges we are facing? In conventional treatment, there is only a one treatment. There is a target to thyroid medicine, anti-thyroid medication only. But in case of integrative assessment, we can see homeopathically how can we treat the patient? How can we manage the patient actually? We have to isolate, first of all, we have to knowledge of disease. According to master's guideline given in organon, first and foremost thing is, first of all, we have a knowledge of disease. Then only we can treat or we can manage these kind of cases. We have to also quantify the data. We have to show the research only, not only seeing the cases. We have to publish the cases also. So all can see the work of homeopathy. First of all, introduction. We all know that how endocrine system acts. there are 4 type of signaling pathway. If we want to know the thyroid, we have to have a basic knowledge about the endocrine system, endocrinology, biochemistry, hormonal effect, physiological action of thyroid on hormone. So we can see here there are type of signaling. Uh, I think thyroid hormone fall in endocrinal signaling. What is the endocrinal signaling? The secreting cell secrete the hormone, runs through bloodstream and target cell beyond there. And paracrine signaling, there are 2 cells signaling. One cell is secreting, the beside the cell is targeting cell. Autocrine signaling, their own secretion like cytokines, different kind of they stimulating own cell. This is called autocrine signaling. Already we know that neurokine signaling, that synapses are there. Now we can see the blueprint. You can appreciate here the anatomy of the thyroid. Uh, there are a thyroid follicular cell anatomically situated uh, below the larynx. We can appreciate here if we see the patient like goiter, hypertrophy of thyroid, then we visualize the inspect. We have to inspect the patient in case there. So in that kind, we have to knowledge of anatomy, boundaries of anatomy, how to palpate. There are primary production T3, T4. We already know that which is stimulated by TSH, that is thyroid stimulating hormone, which is secreted by anterior pituitary, which is stimulated by hypothalamus. We already know this axis. We are not going to wasting much of time. In thyroid cell, there is a follicular structure. We have to knowledge about the histology also. And there are a cell, parafollicular cell, which secretes the calcitonin. The follicular cell, around it, there are cells present which are called as parafollicular cell. Then the vascular structure, we already know. We are not going to do that part. Biochemistry level, how the thyroid hormone produced. For this, we have to understanding the thyroid hormone biochemistry structure. There are tyrosine amino acid in which in their iodine molecules are embedded. This is the basic structure of the thyroid hormone. How can produce it from the circulation iodide form, I minus form, is transported to thyroid follicular cells. You can appreciate here in the slide that with iodide pump, the iodide is transported through the membrane into thyroid follicles. Now in the thyroid follicles, with the help of TPO, it is the most important enzyme, that is thyroid peroxidase enzyme, which has the 2 words, that is organification of iodine. That is iodide converted into I2, iodine form. Now iodine is jointed coupling reaction, we can say that iodine is joined with the tyrosine amino acid and produce MIT, DIT. What is that? It is a monoiodotyrosine, diiodotyrosine, triiodotyrosine, tetraiodotyrosine. How many iodine molecules are jointed with the tyrosine amino acid? We can say that diamino, monoamino. In thyroid follicle itself, within a thyroid follicle, DIT, MIT, that is monoamino tyrosine and diamino tyrosine are destroyed. Biologically, there is no action for DIT and MIT. The remaining T3 and T4 are transported through the follicle in colloidal place. There is a place, storage place in thyroid follicle. We can call it as a colloid. In that also, from that colloidal pool, like a swimming pool, the thyroid hormone already present. Whatever metabolical is need is circulating in blood circulation, and the targeting organ reach there and action produce. We can appreciate here the trapping, organification, coupling, endocytosis, recycling, and local conversion. That is a recycling of thyroid hormone. Now, what is a hyperthyroid? We already know the physiological. We already know the thyroid action. Thyroid is metabolically active hormone. Hyperthyroid. What is happened in hyperthyroidism? Here we have to understand that there is two different thyroid toxicosis and hyperthyroidism, slight different state, but thyroid toxicosis is advanced stage. It is out of controllable stage. So we have to manage accordingly. What is the hyperthyroidism? It is the overactive state. It is a hyperactivity of T3 and T4 hormone, which leads to hypermetabolism. All hyperthyroidism lead to toxicosis, but not all thyrotoxicosis caused by hyperthyroidism. Now, etiological matrix, how it's happened. First and foremost, the most common reason is iatrogenic overdose. Maybe some patients are diagnosed with hypothyroidism initially. They are taking too much thyroidic hormone in conventional treatment. The patient may convert into hyperthyroidism. We have to observe that also. High iodine diet supplements. That is opposite to we have already know the hilly area. In hilly area, there is a less iodine content in salt. So in this test, they produce hypothyroidism test. In case of higher supplementation, the toxicity, there is a too much adulteration or fortification of iodine. It may lead to hyperthyroid. Hormone producing metastasis, there are tumors, ovarian teratomas, they are producing uh, too much amount of T3 and T4. Follicle breakdown, there is follicle leakage. Thyroiditis, there is the inflammation of thyroid gland, which can lead to extra release of thyroid hormone. We already know in appreciate in previous slide that there is a colloid, there is a swimming pool, like the storage of thyroid, T3 and T4 in our thyroid gland. So there is, in case of thyroiditis, in case of injury, in case of inflammation, there is a leakage of T3 and T4 excess amount, which may lead to hyperthyroidism. Autonomous secretion, receptor overstimulation in case of grave disease, thyroid stimulating, there is in gland, there is a receptor, TRS, there is a thyroid stimulating hormone, can stimulate this receptor. In case of overstimulation by antibody, what is the problem here? The antibody binds with receptor for so long, prolonged time. In physiologically, TSH TSH have a half-life. So after having half-life, after having a timing for degradation, TSH receptor not stimulated by TSH and TSH is degraded. But in case of antibodical stimulation, there is the over a period of time, longer duration of type stimulation, which leads to hypersecretion. Systemic blast. What is actually happening in hypermetabolic state? First of all, as a physician, if we're treating, we have to focus in a one main system, that is the cardiovascular effect, that is cardiovascular system. In case of thyrotoxic state, there are higher chance of arterial fibrillation. Patient may lead to emergency condition. So first and foremost symptom, patient may have palpitation, tachycardia, driven by high sympathetic. We already know there is a low vagal tone. Vagal tone is responsible parasympathetic. That is a reduce the heart rate. But in case of hypermetabolic state, there is a sympathetic activity which leads to tachycardia. There is a widened pulse pressure. There is a high systolic and low diastolic, which leads to widened pulse pressure. It may happen due to nitric oxide, vasodilatation, drug substance used in conventional therapy. arterial fibrillation, there is a 2 to 20% chance that a thyrotoxic patient may develop atrial fibrillation. It is an emergency condition, needs to be ICU administration and monitoring. In case of net catabolic state, there is a higher catabolic rate. In case of what is the receiving, we are losing more in balancing with receiving. So net catabolic state is reduced. There is a weight loss in spite of good appetite. There is a lipolysis which is responsible for weight loss, glycemic stress, blood glucose. In case of diabetic patient, the glucose may hamper hypermetabolic state or may lead to hypoglycemia. In some cases, that hyperglycemia shifted. In case of other system, there is a nervous system is most important, which is involved in hyper metabolic state. What is happening here? T3 and T4 metabolically upregulate the beta adrenergic receptor. What is doing beta adrenergic receptor? They are sympathetic active, which regulates the all kind of synapses, chemical receptors, alpha receptor, beta adrenergic receptor, responsible for adrenergic drive. We can say there is a high sensitivity, patient develop high sensitivity towards the adrenergic drive. So which leads to, already we have a hypermetabolic state, hypersympathetic activity. Already patient have upregulation and high sensitivity for adrenergic drive. So which leads to agitation, tremors, hyperkinesia, emotional instability, irritability in that cases. We can appreciate here T3 enhance osteoclast activity, leading to progressive bone loss, osteoporosis, mild hypercalcemia with high calcium and phosphate excretion in urine. We have to remember that for in hypermetabolic state, so we can prescribe the investigation accordingly. GIT symptom like hypermetabolic state, patient may present with diarrhea. Reproductive patient may comes with infertility in that. Hematologically, we can say there is hematocrits remain normal, or maybe there is RBC increased mass due to hypermetabolic state. Now we move towards the Graves' disease, which is one of type of, it is an autoimmune disease. In case of homeopathic treatment, we have so much potential in our pathy to treat this kind of autoimmune diseases. What is happening in conventional treatment? They only blocks the receptor, only give the antibodies. They only given the antithyroid. There is no treatment available. What is the environmental factor triggers responsible? There is iodine excess, smoking, alcohol consumption are responsible. There is environmental high risk factor. There are some in research found that there are some genes which are responsible. This is HLA class. Some HLA class, some major histocompatibility, that is MHC molecule. We can simply say that there are some predisposition that some patients have some tendency towards development of autoimmune diseases like Graves' disease. Essential factor in case of female is a high rate of Graves' disease. Postpartum immune fluctuation are responsible for that. What is actually pathogenesis? We can appreciate in slide that in normal hypothalamo secretion of TSH in case of secondary hyperthyroidism. In case of primary hyperthyroidism, normal. It is an autoantibody which stimulates the TSH receptor, which secretes the high T3, T4 level. In physiologically look, we can appreciate in the slide how the thyroid axis is formed and how in in Graves' disease, how antibody is stimulated. They are mimicking like a TSH. So they are overstimulating, overdrive, over control, not in under control, which leads to hyperthyroid state. This in overtime, this long time of overstimulation of TSH receptor by antibody leads to hypertrophy, hyper division of cellular tissue of thyroid follicle, which leads to hypertrophy. We can appreciate by goiter. We can say goiter. What is the extra thyroid manifestation? Thyroid dermatography, hai, thyroid acropathy, hai, which are rare in both. The most common symptom we can appreciate in patient is grave ophthalmopathy. There is protruding of eyeball. How it happened? Due to inflammatory in hyper metabolic state. There is T3, T4 secretion is high level. With this, in case of base, the base of eyeball, the fat tissue are in hypermetabolic state, which leads to glycosaminoglycans accumulation, which leads to trapping of water, which leads to hypertrophy of fat tissue and bad tissue, base tissue of eyeball, which leads to protruding out of eyeball, which leads to exophthalmos goiter. We can say that exophthalmos. We can appreciate lead leg, ptosis, diplopia, or in advanced cases, there is a optic nerve compression leads to visual loss. No tech score. We can. This is given in Davidson, also the reference book. Also, no spec score. If we find the patient with exophthalmic goiter, we have to find out in which stage patient is coming with us. So we can manage accordingly. In case of advanced, there is a sight loss. We can appreciate here optic nerve compression. We have to surgically intervene. We have to refer the patient for conventional treatment. In case of zero, there is a no sign and symptom. In case of there is a lid retraction, wide eye striae, there is a stage 1. In second stage, there is a soft tissue involvement. In third stage, there is a ptosis. There is a in fourth stage, there is a extravascular muscular involvement. There is a diplopia. There is a more protrusion. And in case of fifth stage, there is a corneal vein. How it happened? Lid cannot close properly, which leads to dryness of corneal layer, which leads to fissure in cornea, corneal damage. The light cannot pass properly. With this, there is a sight loss with optic nerve compression. Diagnostic perspective, hyperthyroid state. If patient come with hyperthyroid state, if we appreciate clinically, there is a patient have a maybe diarrhea, palpitation, high heart rate, patient may have a sinus tachycardia. He may think about patient may have hyperthyroid state. There may be primary and secondary. First of all, we already know that I not mentioned in slide that we have to go for TFT, T3, T4, T3 value. There is a high count in T3, T4 value. There is a reduced count in TSH. We already know that. We are not going to detail of that part. Now I want to mention that how to differentiate patient between primary hyperthyroidism and secondary hyperthyroidism. First of all, what is the difference? The cause. What is the cause? This cause is within a gland, which called as a primary hyperthyroidism. Is a cause outside the gland. For example, there is a one cause pituitary adenoma, which secretes the high amount of TSH, which leads to hypersecretion of T3T4. So we can here say that this is secondary hyperthyroidism. What is the importance? What is the importance to know that that is a primary or secondary? There is a treatment difference. If we know that there is a secondary hyperthyroidism, we have to select the medicine accordingly. The seat of action should be there. if the patient having primary hyperthyroidism, we have to select glandular remedy which effect on thyroid. So we have to differentiate. How can differentiate? If there is TSH amount low, so there is definitely primary hyperthyroidism. If TSH amount is, how TSH is low? Due to secondary mechanism. TSH is secondarily giving feedback to pituitary to reduce the secretion. No, there is a too much amount T3 and T4, not secrete too much. So this can lead to, in case of primary hyperthyroidism, there is a reduced TSH, lower side of TSH value. In case of secondary, for example, pituitary adenoma, there is a higher amount of TSH, which 3 and 3 also higher amount of. In case of Graves' disease, there is definitely antibody present. In case of hypothyroidism, there is anti-TPO antibody. That is, we have already appreciated in previous slide, what is the role of TPO? There is enzyme responsible for iodification production of hormone, which leads to, if there is presence of anti-TPO antibody, leads to hypothyroidism. If in case of Graves' disease, there is TRAB antibody present, which leads to overstimulation of thyroid stimulating hormone receptor, which leads to overproduction of T3 and T4. So how can we go with that? There is a one radioactive uptake iodine. We can appreciate in slide that how we can go for that. In the case of reduce, there is a low uptake. We have to uh, uh, differential diagnosis. We have to go for other differential diagnosis. There is a thyroiditis. If there is a radioactive iodine uptake is increased, there may be a presence of antibody. Ultrasound, we can also prescribe the local ultrasound. We can appreciate hypertrophy also there. So we can confirm the Graves' disease or thyroid multinodular goiter or toxic adenoma. How can we appreciate or how can we go for that? In case of ultrasound, there is a tiny growth are there, which we have to do. We have to go for biopsy for confirmation if there is a benign growth or a cancerous growth. Now we can see over slide here that there is a one thing mentioned. There is a Bruch part of this point scale. What is the BWPS? This is the quantifying for thyrotoxicosis. What is the motive? What is the aim to introduce here this? Uh, there are so many homeopaths, they are showing patients, they are recording, they are keeping records, they are publishing. But now onwards, NCH or NCCRH, that is the Central Council of Homeopathy, promoting research, especially in case of academician students. What is the role of research? If we have to accept the homeopathy works, simply, for example, we can say, if I claim that in case of hyperthyroidism, homeopathy works this kind, but how can all things or internationally acceptable? So we have to do research for that. We have to do case study. Then in above state case series, then we have to do the double blind study, placebo control style study, and go for research study or application of biostatistic in integrating research with biostatic with homeopathy. This leads to more acceptance of homeopathy. So if you want to do research in hyperthyroidism, if you find in Google, there is a lots of case, lots of research available for hypothyroidism, but there are so less case available recordingly, so less research available for hyperthyroidism. So already I have done one kind of research for that. So for that, if patient come to me, they say, doctor, I have a palpitation. I have a this kind of symptom. Already we know homeopathically we take a case, making symptom quality, and then we prescribe medicine. And in follow-up, patient came with us. Now I feel better. But internationally, research perspectively, nobody is accepted that patient is saying, I am feeling better. For that, we have to apply the statistics. Biostatically, it should be proven. So it is a scale to quantifying. Patient came with the qualitative symptom. We already know the symptomatology. We have already organon give us detailed guideline about symptomatology. What is quantitative symptom? What is qualitative symptom? Patient present with qualitative symptom. I feel better. I now onwards I have no palpitation. My palpitation increase, decrease. So for that, we have to convert into uh, in numerical data. For that, we have to acceptable. This scale is given in Bruce-Wartowski scale is given in Davidson. We have to give reference also. Randomly scale we cannot pick up for research purposes. So in that scale, there is a thermoregulation, there is a mark, there is a heart rate, there is a point given 5 point, 10 point, 15 point, 20 point. Accordingly, uh, how to manage patient, it helps. Its score is above 45. There is a guideline that patient must need to admit in ICU. So we have to refer immediately in case of emergency case. If patient came with hyperthyroid, score above 45, there is a neurological examination, temperature, cardiovascular system, atrial fibrillation present or not, congestive heart failure present or not, what is the heart rate. Accordingly, there is a points totality it should be done. If there is a below the 25, we can definitely manage with OPD homeopathically. Below 45, we can manage with homeopathically. In each and every follow-up, we have to quantify with scale. We have to see, we have to observe the patient. This patient is treatable with homeopathy. Can we handle it? Or we have to refer the senior homeopath. We have to consult senior homeopath for that. If patient is worsening, definitely we are applying Kent observation in follow-up and second prescription. With this for pathology, with thyroid hyperthyroid state or hyperthyroid state monitoring, we have to apply this Bruce-Wartowski point scale. Now, we can not wasting much time in allied side. Already we all know these things. How homeopathically we manage the patient. It may take a time for treatment for these kind of cases. It may take a months and years, needs of follow-up. Now, what is doing in conventional? They are only focuses on gland. Hypersecreting gland, we only focuses on gland. Anti-thyroid medication, destroy the thyroid. Radioactive iodine given, and for radio thyroid follicle is destroyed. Now physician is free. No secreting. Now patient hyperthyroid convert into hypothyroid. Now for a long lifetime, they are taking thyroid supplement. Only limited option for hyperthyroid patient. In case of homeopathy, we already know there is a systemic disturbance, vital force disturbance. Already mentioned the cause. Aphorism number 7, 18, 17. There is a local labor. Hahnemann warns that there is a local suppression drive that real disease differ. For example, before some years, patient may take vaccination. Patient may present with the psoriasis, eczema, itching, redness of skin. They are doing topical steroid, suppressing, and then after months and year, patient may present with the hyperthyroid state. So local suppression is very dangerous. In case of reference, already mentioned in endocrinology, Herbert Robert philosophy, there is a suppression of local disease leads to endocrinal axis deviation, which leads to vital force disturbance. This leads to endocrinal pathology. we can apply over here hyperthyroidism cases. There are so many different stalwarts view present. Hahnemann's already mentioned in theory of chronic disease. There is a latent sora, there is a root cause sora may be present. Hetty Kent already say in his philosophy that disease originates the interior. The thyroid symptoms are outward result. The Stuart Clause said that alter receptivity and susceptibility. There is a chapter mentioned in philosophy, there is a susceptibility. If patient susceptibility alters, which may lead to eventually in uh, disease condition. HA robot, I have already mentioned there is a nice dedicated chapter given for endocrinology and pathology from his philosophy. Margaret Tyler also already linked the internal emotion, stress, grief, which suppression leads to glandular imbalance or glandular affection. E.F. Harrington in his clinical book, there is a mention lot of medicine for that. James Crom Burnett very nicely mentioned therapeutic. There is a action of medicine, how medicine act, how to select medicine. In second book, there is how to become homeopath. There is a 50 reason for being homeopath written by James Crom Burnett. There is a different kind of cases present for motivating students which uses your pharmacodynamics, how the medicine action, which is the action of medicine. We have to select, for example, thyroidinum iodine, which has a glandular affinity towards the thyroid gland. So we can appreciate here in slide different stalwarts view. Materia Medica framework. Quickly, we are going with some kind of medicine. This is for educational purpose. We have, as a homeopath in clinic, in hospital, we have to select most the similimum, most the therapeutic perfect one medicine to act the medicine. Now, for acute exacerbation, there is some kind of glandular remedy, iodine, thyroidinum, Lycopus virginicus. There are 2 to 3 cases also mentioned. And Herring also used Lycopus virginicus. If in younger homeopath, they are confused with hyperthyroidism case, they are consulting homeopath or there is senior consulting not available, they can blindly prescribe iodine, thyroidinum or Lycopus virginicus in case of thyroid disease or glandular affection. Constitutional tissue remedy, we already know the deep acting medicine, this kind of spongia, calcarea, aurum, lycopodium. Now, acute nervous affinity, belladonna, kali iode, sepia lachesis. What is a profound action? The remedy iodine, profound wasting, in spite of ravenous hunger. If we are going to select this iodine medicine, these red line symptom keywords should be present. Now, all students are asking me question. Patient present with a ravenous hunger. It is a pathological symptom. In hyperthyroid state, there is a high demand. There is a lots of needs of nutrition. So in this case, already pathologically there is a ravenous hunger is present. But already Stolwar have been given that if there is a 3 mark of pathological symptom, if there is though it is a pathological symptom, we have to consider in totality because it has a higher intensity. So we can correlate with this. This is a proving symptom, ravenous hunger in spite of wasting, loosening weight, accelerated heart pulse in cardiology, CVS action, intolerance of heat, must have cold rate, anxiety is marked present in thyroid. In case of thyroidinum, there is a rapid loss of flesh, profuse sweating, tachycardia, intolerable heat, is present. Lycopus virginica, the general tremor is present. CNS symptom is more prominent in case of Lycopus virginicus. Spongia tosta, hard goiter, dry goiter, dryness is present. We can go for selection of for Spongia tosta. Calcarea iodata, there is a combined salt. I already know that enlarged goiter, indurated gland, profuse sour cephalic sweat is a marked symptom keynote. Calcarea carbonica, most prominent polycrest, most prescribed in clinic. Forum iodatum in case of advanced thyroiditis, in case of leakage of T3, for hypermetabolic state, cardiac failure, cardiac affection. We can think of forum iodatum, forum metallicum. In case of nervous agitation, nervous symptom from patient present with heat intolerance, sudden violent palpitation, epileptic condition, flushed, burning, inflammatory sign, we can think of belladonna, legacy, city is present. Already we know we are not going detail of that part. Less present in Kali iodum, Kalika as a polycrest is the most important for in case of hyperthyroid. Rheumatic heart disease with hyperthyroid state, we can go for this. What is the direction? If patient is come with hot and burning, we can go for sulfur ragged philosopher, heat intolerance. There is a chilly patient, we can think of phosphorus, maybe lycopodium, maybe bloating gas, GIT symptom present, diarrhea alternating with gaseous symptom, emaciation present. If personality mild VP, we can go for pulsatilla. We can appreciate here. In case of sepia, there is a hormonal disturbance. In case of menopausal age, if patient present with hyperthyroid state, we can go for a sepia. GIT prominent symptom. If patient have acute exacerbation of diarrhea, I remember that one patient of hyperthyroid already taking medicine on medication, acute exacerbation happened, patient present with diarrhea in morning. They describe the symptom. As I early wake up in morning, as soon as I uh, wake up from bed, I have to go for toilet. For last 70 days, there are profuse diarrhea. I go for L-Soprotina uh, uh, in lower potency, repetition dose, nice result, control in diarrhea, then after go with other polycrest medicine. So for that kind of we have to go for acute medicine also. What is a mind map? What is a prominent symptom? We have to select medicine accordingly. We have already seen all the things. What is a mind and mental state? This is a, you can take a screenshot of over here. How the pathway happen, how the symptoms present. Patient with trembling, anxiety, palpitation. The root cause may be present over years. What is element from jealousy, mortification, grief, disappointment? From this mental shift to internal state, internalize. This leads to restlessness, agitation. This may be leads to sleeplessness, blurred vision, palpitation, trembling. Navigating repertories, we can use a different kind of repertory. For example, can repertory, there is a blood stain sweat, imperceptible pulse, there is directory rubric given, clinical rubric, clinical repertory, Borix repertory we can use. There is Graves disease, atrial fibrillation, direct diagnostic rubric present. So we can find the group of medicine for direct Graves disease. So selection of medicine becomes easier. Synthesis repertory. Murphy repertory, there is a dedicated chapter, glands. In glands thyroid, we can see the different kind of rubrics. In complete repertory, there is ocular exophthalmic goiter specific rubric is there. In synthesis repertory, there is a specific rubric, hypermetabolic state. There are different kind of repertory, triad of cure, how we can manage the patient. Organ pathology, already we know. Miasmatic root cause, we have to reference the organon and different philosophical background, individual totality. These three combined make a totality and select the semi-minimum for selection of medicine. This is a clinical summary. You can take a screenshot for managing hyperthyroid or any kind of patient. We can go this pathway also. The core philosophy, the diagnostic kit, and then go for selection. Now, I want to describe some cases. There is one patient, I not disclose his identity. There is we have much less time, so I am going fastly in history also. Already diagnosed patient, case of primary hyperthyroidism. This patient is seen by me in Sainath Homeopathic Hospital, which attached with our college, Rajkot Homeopathic Medical College. A nice result. Patient present means to describe. So I feel so hot all the time. I also taken the guidance of senior homeopath, my principal Dr. Hikat Mehta sir in this case. Patient narrating symptom that there is a feeling, there is something unusual present since the last 3 months. After 3 months present with me, doctor, I feel so hot all the time. I can't bear the heat. Patient fanning herself vigorously despite of room is cool, AC is present, appears restless. My heart is always racing, heart is always running. Doctor, I feel so hot. I am eating like a horse but still losing weight. Ravenous appetite. Patient appears thin, prominence clavicle. I can appreciate in clinic also. There are prominent clavicle like me. There is a much emaciation present. Aggravation, evaluation already mentioned in slide. There is a palpitation, trembling, slight emotion which leads to aggravation. Patient have to rest. In stomach, we can appreciate angry, hungry sensation, meal delayed, associate symptom, increased frequency of stool. These we can consider pathological symptom also. Fine tremors also present since 3 to 6 months. Go for investigation. The TSH value is low. So for upon this, we can appreciate there is a primary hyperthyroid state. 202 nanogram per DL, T3 value, T4 value also higher side. Already I have applied the scale. Scale is 20. In normal physiologically, it should be below 5 or 0. Here the scale is score is 20. Patient have a high temperature, 140 vitals normal. What is a life space investigation? What is find in patient? I describing in short. The patient was a primary school teacher. She described herself as a very active and responsible person. She took a early retirement. Already so many years present for duty, but she left out her take a early retirement. Why? Because take care of her aligned mother. Mother is dependent on her. Who passed away? Mother is passed away before 10 months. Now we can here link the link. The patient symptom present since 3 to 6 months and before 10 months. her loved one mother is passed away. And then she internalized her grief and felt she had to be strong for a family. Shortly after this period, her current symptom began. She feels constant urge to be useful, cannot shoot ideal. Hurriedness, hurriedness in talkative, I can also appreciate in my clinic, in my follow-up also. Anxious, restlessness, cannot stay in one place. Conscious about referral, one of the rubric I already taken. Physical examination, physical appearance, anxious look, jaundice, anemia, cyanosis, thin built appearance, emaciated, temperature high, already mentioned, tachycardia, inspection of thyroid gland, slight, no visible goiter. Um, there is no bruit present on auscultation. In case of thyroid cases, we have to put the stethoscope to, in case of presence of bruit, we can appreciate in some cases. Already T34 value I have mentioned. I have already done miasmatic evaluation prominently from my side. It's leukocytic miasm due to internal anxiety, hurriness, sensitive to heat, never enough. I go for, I already mentioned here that I have to do work for, you can take a screenshot of it. She internalized her anxiety, her sensitivity is hampered, which leads to hypermetabolic state, hyperthyroidism. I already done the totality of symptoms. Do the repertorization. Why I choose iodine? The already I have mentioned that James Crom Burnett also mentioned that if we going to prescribe medicine, we should go for the kind of medicine, the seat of action, the kind of action. So what is the seat of the medicine? Have to be glandular, have to be act on thyroid. Then and then only cover the totality and prescribe the medicine. The core symptom, ravenous, emaciation, already present, I already described. So go for a prescription thyroidinum 200 waistline. With this auxiliary measure, due to loss of fat, I prescribe high calorie, high protein diet. Strictly all patients in the case of hyperthyroid, elimination of uh, caffeine, reduce sugar. We have to also diet and regime also portion should be take care of. In follow-up, in initial follow-up, patient not much improve, palpitation improve. I already repeat the medicine, whatever need. Also prescribe sometime acute exacerbation. For example, patient with palpitation go for digitalis and cardiac medicine. Categories in some other cases, not in this case. In some cases, patient may present with some cardiac issue. I go with some acute medicine because Kent already mentioned that first treat the acute first. You can appreciate after follow-up, there is definitely some reduction in marked improvement. Patient feels so much better. You can appreciate the TSH value, which in previously 0.07 from 2 point almost normalized. Though here is T3 value is not a normalized, but need of more follow-up assessment. TSH is regulated by hypothalamus. So our main aim is to, with managing these kind of cases, the more vital for core is stimulated, vital for is definitely stimulated, the hypothalamus definitely stimulated. The first improvement definitely seen in hypothalamo pituitary axis, which can appreciate by TSH value. Then and then after T3 and T4 value, less normalized happen. T4 value good improvement 11.11 microgram per deciliter. You can appreciate in this report also. There are so much less time going present, so going with first, second, and last case. These patient present with patient is present with actually a tightness of throat, coughing symptom. Coughing since more than 3 months. Already they consulted respiratory lung specialist, no cause found. Initial, they prescribe reports and find that patient have a hyperthyroid state. Patient economically cannot able to afford. So came with me in Sainath Hospital. Patient have a higher heartbeats, palpitation also present. Already mentioned. She A patient comes from middle class family, been under financial stress due to her husband business difficulty. Her husband business flop out. Taken of tailoring work to support the family. Described as a warrior, anxious. She have taken some rubric, anxious about her fear of suffocation. Religious, wept. During consultation, also patient weeps with coughing symptom. There is a dryness also patient. There is a higher scale. You can appreciate also that I make a totality for that and go for spongia. Then after follow-up assessment, I have so much less time, so I am uh, this you can appreciate over slide there. There is a marked reduction improvement after follow-up assessment. There is normalized TSH value. Also needs some more follow-up. Patient is already currently also under my observation. Thank you so much. This is my presentation.
Thank you so much, doctor. Actually, you have explained clearly and detailed explanation about hyperthyroidism from the beginning. You arranged the slides even very clearly. This, I think Dr. Ram Parvesha sir have to say something about that. Today's educational seminar was truly super. You have some messages here.
Yes, sir.
Truly super, majestic, and
Thank you. Thank you.
filled with knowledge. From Vivo, shall I open? Shall I unmute you? You can speak. We have 2 minutes more. Dr. Ram Parvesha sir, you can speak.
Thank you, Dr. Andini. Everyone, namaskar and congratulations, Dr. RAXIT VISHPARA. Very nice, excellent session. Tell, describe the physiological action, physiology, hyperthyroid. Hyperthyroid is an autoimmune disease. Excess hormonal balance and excessive. There are main symptoms. Excessive hunger, but weight loss, first symptom. And heat, patient is hot, heat. And anxiety, a stress in large thyroid. So a lot of medicine, लेकिन what disturbance according to role of homeopathy. Sura is a background, very important, and mental symptom is a very important. Constitutional treatment and background of
Thank you.
and Sura.
Thank you, sir. We have only one more minute.
Very
Dr.
thanks, Dr.
Nakum.
again presentation.
Pratik,
Behalf of
you can speak.
IFPS, very thank you.
Thank you.
Okay, thank you.
Thank you.
Yes, yes.
Ghar Ghar
Hello.
Homeopathy. Ghar
Dr.
Ghar
Pratik, you
Homeopathy.
can speak now. Please.
Yes, yes. Just only want to say that wonderful explanation by Dr. Rakshit, and it's hyperthyroidism is a very complicated topic nowadays among the other doctors also, because we can't judge on the basis of symptoms and all that kind of stuff. We have to going to lab test and all that kind of stuff, and its homeopathic management is also very vast subject. So it's not rely on one medicine also, because you have to gaining more and more knowledge about medicines, so that you can conclude up to one or two medicines which can really affecting on the hyperthyroidism wonderfully. So that's the kind of stuff, and that's the kind of beauty and magical we can say the homeopathy has. So I just wanted to say that homeopathy is very wonderfully acting in hyperthyroidism as well. So that's the I want to say.
Thank you, Dr. Pratik. Now it is a time for the Malayalam session. Dr. Boblim, are you there to say a vote of thanks? Okay, then on behalf of IFPH, I'm from my side also, I'm saying a big thank you to Dr. Rakshit. Thank you so much. Come again with the with another topic. Thank you so much.
Thank you.
Now we are moving to Malayalam session. Thank you all the participants of the English webinar.
Thanks a lot.
Thank you.
Wonderfully arrangement by you, madam, also. That's the wonderfully arrangement, all these sessions.
Pardon?
Wonderfully arrangement, all these kind of sessions you have
Thank
arranging.
you. Thank you. I am accepting your thanks and appreciation to the whole team of IFPH. I'm giving credit to all team of IFPH.
Also interested to share some topics regarding homeopathy and its homeopathic management later in future in this platform also. If you allow.
You can contact to Dr. Danesh and you can say. Thank you so much. And now I am inviting Dr. Mariamma John for moderating Malayalam session. Good night, everyone. Love you all. See you the same time tomorrow. Bye-bye. Dr. Mariamma, you are welcome.
നന്ദി അജിനി ഡോക്ടറെ.